Hello, I'm Dr. Andrew Cutler. I'm CEO and Chief Medical Officer of Florida Clinical Research Center and Courtesy Assistant Professor in the Department of Psychiatry at the University of Florida. And I'm really proud and excited to be here once again at the 2013 AACP annual meeting. It's my pleasure this morning to be giving a talk on managing major depression and making effective clinical decisions. The problem for clinicians is that even with our currently available treatments, we still have residual symptoms, and we are now learning about the importance of not merely getting to response, but getting patients with depression all the way to a full remission. And some of the common residual symptoms that prevent us from getting to a full remission can include fatigue, problems with concentration and memory, insomnia, as well as the painful symptoms that are sometimes associated with depression. So we'll be talking about strategies to manage those kinds of residual symptoms to get your best learned long-term outcomes. In addition to talking about some of these issues and understanding them a little better and categorizing how we think about them, we'll also be learning about some practical solutions to some of these problems. For instance, we'll be talking about how to choose between the currently available antidepressants, such as our SSRIs, selective serotonin reuptake inhibitors, our SNRIs, which are serotonin norepinephrine reuptake inhibitors. We also have newer agents that are going to be working on different kinds of receptor profiles. We have also agents that work in different ways, such as bupropion, which is non-serotonergic. And when we talk about getting to remission, of course, when we understand what some of the residual side effects, some of the residual clinical problems and insufficient response symptoms are, we can talk about some of the biologic underlying mechanisms. For instance, agents that simply increase serotonin have been associated with some disturbances of sleep and also sexual dysfunction. We're learning more about the importance, for instance, of increasing serotonin and its effects on a postsynaptic 5-HT2A receptor and even presynaptic effects of that receptor. And so thinking about ways to deal with that, first of all, if we understand that receptor down the road actually leads to a decrease in dopamine release, and dopamine is critically important for proper sexual desire and function. There are strategies such as using agents that are agonists or partial agonists at the 5-HT1A serotonin receptor. That appears to help counteract some of those effects of the SSRIs. We know also that the SNRIs, by virtue of increasing norepinephrine in addition to serotonin, may be associated with some more beneficial effects for motivation, concentration, and energy. We also know that the combination seems to be important for managing pain, for instance. We know that some of the SNRIs, by increasing serotonin and norepinephrine, they've been shown to be effective in managing some of the physically painful symptoms of depression. And we're learning more and more about the mechanisms of serotonin and norepinephrine, not just in the central nervous system, but in the ascending pain pathways in the spinal cord. And it appears that chronic pain and depression can deplete serotonin and norepinephrine. Now, we'll also be talking about managing insomnia versus managing some of the sedation of the currently available antidepressants, and also weight gain. We know that medications that bind to or block histamine receptors, H1 receptors, can cause sedation and weight gain. And so we'll be learning about ways to choose amongst the antidepressants to either take advantage of that and help with sleep, and maybe even help with some patients who need an increase in appetite or could benefit from some weight gain, versus others that we could even think about switching to or augmenting to help deal with those side effects. We'll also be talking about ways that we can enhance not only the amount of sleep, but the quality of sleep that a patient with depression might have problems with. For instance, we're learning more and more about the role of melatonin, and especially the circadian rhythm and the sleep-wake cycle. And so we've learned now that melatonin receptor agonism, stimulating melatonin receptors, and there are various ways to do this, can be used to help not only with inducing sleep and the quality of sleep, but some patients with depression have been found to have significant disturbances of their sleep-wake cycle, the circadian rhythm, if you will, and using melatonin properly at the right time of day can help reset the clock, if you will, of the body. Now, we're also learning about the role of other receptors, serotonergic receptors and norepinephrine receptors, such as the 5-HT7 receptor. Now, there are 7 families of serotonin receptors. 5-HT is the chemical name for serotonin, 5-hydroxytryptamine. And the 5-HT7 receptor, if you antagonize that receptor, it turns out also is a way of resetting the biologic clock and helping with circadian rhythm and sleep-wake cycles. We have some medications that are in development and actually awaiting approval from the FDA, and there's others that are in development that take advantage of what we've learned about some of these different receptor subtypes, for instance the 5-HT1A and the 5-HT7 receptors. So I want to thank you very much for your attention, and hopefully this has been educational and informative. And I want to encourage you to also attend the meeting, the AACP annual meeting, and to check out the Current Psychiatry website for more information such as this. Thank you.